The study is the brainchild of researchers at the University of Pittsburgh. I have an interest in liver failure and bridging therapies for transplantation. We also have a very active research program here in liver transplantation. And that's how we came to be involved with LyGenesis in this trial. We immediately started to brainstorm about how this technology could be used to save patients who have liver failure without options for transplantation, and even those patients who may be candidates for transplantation but are too sick for transplantation at that time. My name is Dr. Constance Mobley, and I am the Associate Director of Liver Transplantation at the J.C. Walter Jr. Transplant Center, and the Medical Director of the Surgical and Liver ICU at Houston Methodist Hospital. I'm the principal investigator at this site for LyGenesis study. It's a dose escalation studies, and initially the first bar to clear is that of safety. So the first cohort of patients has been to determine adverse outcomes. We're using a low dose of cells. Around 50 million cells are injected into one lymph node. The study is to determine the number of lymph nodes that need to be injected and the amount of cells that need to be injected. We're hoping to meet out some of those characteristics during this first cohort. The second cohort will have 3 lymph nodes injected, and then the third cohort will then have even more lymph nodes injected with more cells. This study actually so far has been successful. Ideally, what we would like to see is a decrease in bilirubin levels, a decrease in AST and ALT, a improvement in INR. Clinically, we would like to see their encephalopathy improve. We'll possibly even see some reversal of hepatorenal syndrome that we see in these patients. One of the most interesting aspects of this study is the impact that it can have on numerous patients. So we have patients who may have a low MELD score who are very symptomatic and not candidates for transplantation because of their low MELD score or don't have easy access to organs. Because they still may have a lot of symptoms, this may be therapy that allows them to either reverse the symptoms that they have or stabilize them until they are able to get transplanted. In addition to that, there are patients who are very critically ill in the ICU with liver failure and may be too sick to go to transplantation because of the acuity of their disease. This technology may allow us to stabilize them so that it's safe to take them to the operating room. Theoretically, if we get good enough at this technology, we may be able to intervene on patients at early times of diagnosis of cirrhosis, possibly even before they have significant symptoms, and stabilize their disease before they decompensate and need transplantation at all. At some point, this technology will supplant the need for transplantation. So one of the great things about being a physician as well as interested in research is that you're able to see the impact of the decisions that you make daily on patients or families, and their recovery. When I see patients at the bedside and I see that there's a gap in the ability of us to be able to take care of them and get them back to health, then that immediately makes you want to think, how can I fix this? And that's what doing research is all about. Within the next decade, my hope would be that we see far fewer patients who are succumbing to liver failure. This technology, I think, will take the lead in trying to provide an avenue to restore liver function.